Thank you, Rohit sir. Thank you very much for letting me speak on oblique dysfunction in committant strabismus. So this is something we will be speaking on in our talk of 10 minutes, mainly about A and B patterns, which coexist with the horizontal deviation. Uh, technically, this is not a Technically, this is not a committant squint, but the committant part is that fixing right eye and left eye, the amount of horizontal deviation is almost same. Uh, I think this we all know that if there is an infraoblique overreaction, there would be a V pattern. We know the basic function of infraoblique, and this would be a V pattern means that the eye would be moving outside when the patient tries to look up. And it would be adducting when the patient tries to look in the down gaze. So in an V ESO, it would be ortho or exo in the up gaze, and down gaze, the ESO will be more pronounced, and in exo, the exo will be more pronounced in up gaze, and it would be, the exo would be reduced in the down gaze. So these are some of the patients. I just want to quickly show the infraoblique overaction and the pattern which would be associated. You can see the kid has a small ESO in the upper video and has a small exo in the lower video. You can see that the ESO increases, and when the kid looks, so this is the left infraoblique overaction, this is the right infraoblique overaction, and so in this you can see that the kid looks on the left. So this is, both of them are bilateral infraoblique overaction. You can have symmetrical infraoblique overactions, you can have asymmetric infraoblique overactions, and sometimes you may have masked, which means that if you operate one of the eyes, you may end up into having infraoblique overaction in the contralateral eye. This is post surgery. This was post surgery. We did both eye lateral rectus with both eye infraoblique overactions. We did both eye infraoblique recessions. So the A pattern is okay. This is wrong. This is supraoblique. Cut and paste error. This is supraoblique muscle, which is intorted depressor and abductor. So the A pattern obviously is the drift increases in the down gaze, just like in V pattern. We have the drift, the eyes go out. This is mainly because the supraoblique is abductor, especially in down gaze, and when the patient tries to look in the down gaze, the abduction is pronounced, and that shifts the eyes outside. These are again, these are two videos. I would just like to show. Okay, we'll remove the music so that we can see the. Okay, just see the obliques. This is showing the right eye supraoblique overaction. Just to give an idea. So how do we measure them? We measure them in the side gazes, and most importantly, we measure them in the up gaze and down gaze. It is very important to measure them for near and distance. For when you want to measure them in up and down gaze, two things can be done. Either you can move the target. Okay, so you should always use the target. Torch is not something which should be used for measuring the strabismus. It is all right for the examination part, but if you are measuring the strabismus, you should be using a target so that your accommodation is under control. So you can move the target, or you can move the head, which means that you can tell the patient to move head, and so he will be essentially looking down. It is fairly important to know how much up and down you are measuring. It is important, and it is also important for a strabismus surgeon to keep the vision chart. It is not like general ophthalmologists who normally would keep a vision chart up in their clinics. So it should be at the eye level, so that we do not end up measuring primary position as actually an up gaze position or a down gaze position. And this quantification is important. You can do it on synaptophore or measure the chin up, chin down with the help of a cephalodiviometer as devised by Dr. Sharma sir. So you can, for torsion, you can take a fundus photograph, or you can do a double Madoff rod. So torsion has also been implicated for A and V pattern. So the one theory is that when the supraoblique or infraoblique is a abductor in up or down gaze. Another theory is that if there's an infraoblique overaction and the patient tries to look up, essentially both the eyes would extort, and this would shift the superior rectus on the temporal side and would abduct the globes. And the reverse is true for the supraoblique overactions. Management is in the presence of oblique dysfunction, appropriate oblique muscle has to be weakened. The procedure of choice depends on the severity of oblique overaction and the severity of pattern. For infraoblique recessions to myectomies have been recommended. I personally do recessions, but there are senior guys who say that in their hands myectomies are very good. For supraoblique posterior tenectomy and recessions have been advocated. I do posterior tenectomies of supraoblique mainly for A patterns and split lengthenings. And okay. So this is these are just we will just quickly see the recession of infraoblique. Again, okay, a lot of music. Thanks. So you hooked the infraoblique. I think all these surgeries have been shown yesterday also, but I would just quickly say one or two things. So this is a Parkes recession. This is a Finks recession. In this video, we will be removing the muscle first and taking sutures later, which is the preferred mode. There are surgeons who do take sutures first and then cut the muscle. I personally believe that if you do that, there would be some part of the muscle which would be inadvertently removed. So it is better to cut the muscle first, because you can cut the muscle very posteriorly, but you cannot tie the sutures very posteriorly. It is very difficult to go almost very close to the macula and pass sexovicral, but it is easier to tell the scissors to do that job. You can cut the muscle easily, and we don't have much time. We will just forward it and try to see the surgery. So this is after removing the muscle. See, you can clamp the muscle. You can remove. So this is where we have removed the muscle. And here we will be tying the sutures first. So here we have just done it. So normally this is Finks and this is Parkes recession. There are tables available where you can see how much to do for what. In Parkes, 3 mm inferior and 2 mm lateral to inferior rectus is what we have to do. In Finks, for a classic 8 mm Finks recession, we have to do 6 mm posterior and 6 mm inferior from the lateral rectus. So that is what will be done. And these are for supraoblique. These are the. So I agree with Dr. Rohit that we should try to tackle supraoblique from the temporal route, but in this case we are doing it from the nasal route. Nasal route has a small risk that if you don't suture the conjunctiva properly, you may end up with simulafrons. So it is always better to tackle supraoblique. Even if you are going to do surgery on the nasal side of supraoblique, you should tackle it from the temporal side. So this is supraoblique has been hooked. This we do if we want to tackle both the torsional and the abductor component and overaction of supraoblique. We believe it is a good procedure, and I don't do many expanders, but I do a lot of split lengthenings. And this is the lower video is showing a posterior tenectomy of supraoblique, which was shown by Dr. Rohit yesterday. This is we have tied the sutures on two ends, and we will be splitting the muscle from between. So it is also known as Z tenotomy of supraoblique. Essentially, it would we would okay. So these are the two ends. We will be anastomosing the two ends. So that will essentially lengthen the supraoblique. So that the only concern in this particular surgery is that that is only a concern. It has not been reported. There are only two case series which have been reported. The concern is that this may give way. So that is the only concern which has been more of a concern and not really reported. And in this, you have to preserve the anterior fibers of the supraoblique and remove almost 8 to 10 millimeter area of posterior fibers of supraoblique. So this would spare the torsional component and would only be acting on the abducting component and mainly the A pattern and little bit on the supraoblique overaction in adduction and depression. So I think this started again. Okay, this is finished. Yeah, so this is about my talk. We can take questions and see the videos.
Thank you, Dr. Jitendra.
Thank you, sir.